Hello, good afternoon, welcome everyone. Thank you for joining us today for our webinar facilitated by Hunter New England Central Coast Primary Health Network and being presented by Hunter New England Local Health District's Diabetes Alliance team. So today's webinar will be discussing Hunter New England's Diabetes Alliance Urgent Care Service and how it works from the general practice perspective. My name is Charles Broadfoot and I'm one of the Professional Development Officers with the PHN. I'd like to begin by acknowledging the First Peoples and traditional custodians of all the lands that we are meeting on today, pay my respects to elders past, present and emerging, and also welcome any First Nations people who may be joining us online. So today's session is being recorded and the recording and the presenter slides will become available in our education library on our website within the next 24 hours. So to access these, you just head to our homepage, thepHN.com.au, and click on the Education tab. There will be a short evaluation survey that'll automatically pop up when the webinar ends. If you could just take 1 minute to fill this out before you log off, we really appreciate any feedback that you can provide us. You'll see in your control panel, there's a chat questions box. Please type your questions in at any stage throughout the presentations, but please know we have allocated time at the end of the webinar to go through these questions with our panel of speakers. So now it's my pleasure to introduce today's speakers. So firstly, we have Dr. Damien Jackal, who's the staff specialist in general medicine and diabetes at John Hunter Hospital and Belmont Hospital. We're also joined by Dr. Joe Ferris, who is a general practitioner at Total Healthcare in Foster. Tamara Whitworth, who is the Diabetes Alliance credentialed diabetes educator and clinical nurse consultant with the Hunter New England Local Health District. And last but not least, we're also joined by Wendy Ferris, who is a credentialed diabetes educator at Total Healthcare in Foster. So that's all from me. Thanks again for joining us. I'll hand over to you, Tamara, to start your presentation.
Awesome. Thanks, Charles, and hi to everyone out there watching. And so for those guys that didn't catch our first webinar, I just wanted to, introduce the urgent care model a little bit, and hopefully you can see my slide on the screen. So in response to COVID, what we did see was that a lot of patients were avoiding healthcare and presenting to ED sicker than previous, or missing their routine GP follow-up appointments and presenting to GP land a lot sicker. And so we, as a response to that, decided to create an urgent care model. And what that was is it's district-wide. It covers all of Hunter New England, and we have had all of Hunter New England-wide accessing the services, which has been great. We wanted to utilise the resources we already had, and we really have noticed in the last 12 months to 2 years an increase in referrals to our service. So part of the urgent care response was to look at how can we reduce the burden to acute care, but upskill and support you guys out in primary health, because you guys are at the front, obviously, of healthcare, and diabetes particularly. These patients are regularly visiting their GPs for help, medication scripts, etc. And the ideal model was to be that it would discharge the patients back to you guys into GPs, not come into our service. So that would reduce our referral load, upskill you guys with confidence, have your patients, acute problems addressed, and then you follow up rather than our services. And with the Diabetes Alliance program, which we've been working on now, I think it's over 7 years, we've established great relationships with you guys out in primary healthcare, something we're really proud of. And we're really, our confidence has been built in primary health. You guys are way more capable, and you guys can definitely handle diabetes out there. And we wanted to continue that relationship, upskill, and discharge the patients back to you. So that was where it sort of came from, really responding during COVID times where patients were avoiding healthcare. How could we support you guys out in primary health? And it's been really great. So we started almost 3 months ago now, and the response and uptake has been wonderful, but obviously we want more people to call. And so if I can just click here, we've been really promoting this service in different ways. We've faxed out a flyer to everybody. We emailed out a flyer. We did a webinar 4 weeks after we started. We've been talking with the Primary Health Network and PCIOs that get out into GP land and making sure that they promote the service. We've actually sent out flyers, which you can access the flyer, which I'll show you shortly, to over 300 GP surgeries and primary healthcare facilities in Hunter, New England. We have a Facebook group, the Hunter Region Practice Nurse Facebook group, which we've discussed our service on because it's not just for GPs, it's also for practice nurses. So we want GPs and practice nurses to call for any diabetes related issues, however minor. It is called an urgent care, but it's not about the patient requiring urgent care. It's just urgent in response that we will answer the phone when you call, and if we don't, we will call you back within an hour, and that's kind of our promise to you. So you will get an urgent response. It doesn't mean the person you're ringing about has to be urgent, because we know in primary care, if you get someone urgent, you're obviously going to send them to ED and into hospital care. So we're happy to take any call about any diabetes issues. We also are available, and all the information about this service is on Health Pathways, and I know this is promoted a lot through the PHN, so there is some information on there as well, obviously the contact number on who's appropriate to call through about. We don't do pregnancy, we don't do paediatrics, we don't do acute foot issues, but if you call about those issues, we do redirect you to the correct people, and obviously we're diabetes, not endocrine. So how have we made this work so far? We've diverted all of Switch at John Hunter to our urgent care phone. So any phone calls coming from outside, but even internal, have been redirected to the phone. I man the phone 3 days a week, and my colleagues hold it the other days where I'm not working, and we answer those phone calls. Like I said, if we don't answer, we ring them back within an hour. If it's something that's not eligible or it's internal, we redirect, but all the other phone calls we're happy to deal with. We've also done a lot of promotion around this. We've presented it to the Chronic Disease Network. Other services, cardiology, renal, are all looking to uptake a similar model because it has been successful, and it really has shown that from a financial point of view, that this model works really well, and it really supports you guys in primary healthcare. So this is the poster I'm talking about in front of me. It's got the number really clearly written there, and it's very basic and easy to see at a glance what sort of things we offer. We have posted these out to over 300 surgeries, but if you want a copy today, there is a little tab on the webinar where it says handouts, and you can actually find that poster there. So you can click on that, print that out, and we really encourage you to put that in pigeonholes, in the staff room, promote it around your surgery, because it is, a great resource. So what happens when you call through? We enter the phone and we sort of look at 3 different avenues. We offer advice, we offer medication advice, up titration of insulin, sick day management, insulin pump failure advice. We redirect you to other services. We're sort of a one-stop shop for diabetes. You guys have to know a little bit about everything, all health conditions. So, it's not expected that you know the changes and new services that pop up every day. That's for us. So if you ring us and ring through, we can definitely redirect you to where you go. We also offer insulin titration assistance, so we can take that burden off you if you decide that someone needs a bit of extra support. We're happy to call them for 3 weeks. A weekly phone call to increase their insulin or decrease if needed, and then we feed back to you and hand the patient back to you for ongoing management. And we give you some advice around ongoing titration if it's required, or if we do suspect they need a bit more specialist care, we can offer a case conference with our endo. So that's something that's really been utilised. People ring through with a patient scenario, and we have a weekly endocrinologist case conference appointments that we can offer patients, and they've been booked up. We've had lots of those and lots of great outcomes. So they involve you, the GP, the practice nurse if they're wanting and able to attend due to time, the endocrinologist, and one of our diabetes educators, and plus or minus the patient. So for billing purposes, the patient doesn't have to be present, but it obviously is great for them to be included in the decision making. One thing we have noticed with our My Virtual Care case conferences that we've been offering is, I guess, the tech issues that come with using telehealth. And so what we've actually done in response to feedback from stakeholders is we've extended the time of our appointments. So previously we were booking for 20 minutes, now the appointments are 40 minutes, but what we do find is the GP will stay on for 20 minutes, and then they will go off and obviously have more appointments because you guys are very busy, but we keep the patient a bit longer just to finalise a bit of education. So it's not so rushed for the patient, and they really understand what they need to do moving forward. The other thing that we have noticed because of tech issues is that patients struggle utilising My Virtual Care for whatever reason, lack of access, I guess a fear of technology. So we've made it a little bit easier moving forward that we actually offer the patient now to come in face-to-face into our service. They can also attend the GP surgery if they want to. And Hunter New England has been reduced down to amber alert now from red alert due to COVID. So we are now back to seeing face-to-face patients, which is great. That obviously also helps the endocrinologist here on the day because they can do their face-to-face assessment of the patient, which gives them a little bit more holistic care. If the patient can't attend face-to-face, then we phone them in. So we no longer offer them a My Virtual Care option because at the end of the day, the specialist really can't do a lot of assessment over a webcam anyway. And we just find that the tech issues of getting the patient onto My Virtual Care was taking up too much of the time. So we now offer them face-to-face, and if they're not able to attend face-to-face, then we phone them into the case conference, which works just as well. We've held a clinic this morning and all 4 patients were phoned in and it was quite successful. In terms of My Virtual Care, I'm going to talk a little bit after this spiel about how the GPs can use that, because I know that has been a bit of a barrier for some GPs jumping on board, and that's why we've got Wendy and Joe who've used our service to really reiterate how easy and simple it is, but I'll talk about that in just a minute. So as you guys are really familiar with health pathways, this is one way you can access that number if you misplace that poster. So jumping on the health pathways, you can definitely find all the resources that you need. This is what will appear, and it talks about what we offer, what we don't offer, eligibility, etc. And just so you do know that number, which if you were at my webinar last time, I talked about voting for me. So it's 0436 276 161, and we are here Monday to Friday, 8:30 till 4, but obviously not public holidays, and we don't take text messages. So what have we done in the last couple of months? We're almost at the end of month 3, but looking back at our stats, it's been really interesting to see. Month 1, we had 60 phone calls. 30 of those were eligible and 30 weren't eligible, and a great proportion of our ineligible patients are endocrine. So that's really highlighted for our service and our managers and things that endocrine need a bit of support and might need their own service in regards to this. The outcomes from that was 8 advice onlys. 1 patient came on to titration, and the rest went into a My Virtual Care clinic. Month 2, you can see we had 49 calls, 27 were eligible, 4 received advice, 1 was titration, and then 21 went into a My Virtual Care. And this 3rd month, let's see, but it's definitely been busy, that's for sure, which is great. It means our information and our numbers getting out there, and that's what we want. So just for your knowledge, from a My Virtual Care case conference point of view, in the first month, we had 29 people booked in. 22 of the patients attended, so 7 didn't have patients attended, that's fine as well. The overall outcome, obviously, to discharge back to the GP, so 21 of those consults went back to the GP, not into our service, and the other 8 obviously ended up with a follow-up with endo for whatever reason. 6 were referred on to our services, diabetes education, and that's something that we follow up with a paper trail. It's not something the GP needs to do. 7 went on to see our dietitians, and 4 went on for titration after their My Virtual Care clinic. Month 2, you can say similar, so 20, 16 with the patient attendance, 7 went back to the GP, 13 ended up with follow up with the endo. I think that comes a little bit down to the staffing of these clinics and confidence, I guess, a little bit. We did have one of our senior clinicians unwell for one of our clinics, and so one of the registrar advanced trainees had to take over, and I think their confidence in terms of discharge was a little bit less. 4 into diabetes educator, 4 into dietitian, and then 5 into titration. So you can see we're definitely receiving the calls, we're definitely doing the My Virtual Care case conferences, and the feedback has been really good from all stakeholders. Definitely doing it as a diabetes educator, we're upskilling and learning lots. The GP feedback has been amazing. The practice nurses that have had the time to attend have really enjoyed the process as well. So I just quickly wanted to jump on here for the My Virtual Care. So yeah, as I said, some of the feedback has been apprehensive to use the service, because if they ring through and we decide they need a case conference with one of our endos, we do that through My Virtual Care. And then people go, oh, that's a bit too complicated. One of the barriers we're probably finding is the admin staff. They're a little bit nervous about offering it, and they decide, oh, I need to have a chat to the GP first, and then it gets a bit messy and a bit missed, and it just doesn't happen very efficiently. So if you are happy to go ahead and have My Virtual Care or telehealth appointments in your surgery, I think it's really important to let your admin team know, just so they're confident in making that appointment on the first phone call with the staff, rather than having to ask you and permission, etc., etc. So My Virtual Care, I really want to highlight here, it's not a downloaded software. You don't need to download anything. Nothing will appear on your apps or onto your desktop. It's literally clicking on a link that takes you through an internet browser. So you can use it on iPads, you can use it on laptops, on desktops, on any smart device, on phones. So it's you really don't have to be in the centre or in your GP practice at the time. It's very portable and it's very user friendly. I understand people's apprehension with previous things like Skype and things, and you've got to join and you get verification codes and things, but this is really simple. So you click on the link. That link is what we send you in an email when we book the My Virtual Care case conference. We contact the patient and explain it. We organise all that in the background. All you guys need to do is confirm the time, and then we email you through the link, nothing more. There's not a lot of paperwork and background stuff that you guys are needing to do. On the day, at the time, you click on that link, and then you follow the prompts to log in. Very simple. It just asks names and contact details. You quickly test your audio, obviously. If you don't have a video, that's fine, a webcam. We can just do it through audio. And that's the other thing. If you're still very apprehensive about My Virtual Care, we can do a case conference where we phone you in as a GP as well. The problem with that is we phone the GP and then we're on the 20-minute sort of introduction message to the surgery, because the admin girls are really busy and it really doesn't work for time. So if you do decide we're going to do a My Virtual Care, but I want to be phoned in, we really need a direct number to you. So we're going to test your audio. It literally prompts you through super simple. And then you're going to enter the appointment details, not rocket science, and then you come to a waiting room. And then as soon as our specialist and diabetes educator are ready for the appointment, they'll appear on the screen. You don't need to click on anything, join rooms, all that sort of thing. It's all directed by us in the background. And also, we understand as GPs, you're busy, you run late, so we're very flexible. We switch people around last minute, and that's, I guess, one of the other bonuses in terms of using telehealth, is that you can be a little bit flexible with time. So it's all about communication. But yeah, so you just jump in, you'll be sitting in this little waiting room, and then we'll join you. And then we phone in the patient together. So one of the benefits is with phoning the patient is that we can have a chat beforehand, get a bit of an idea, and then phone them in and discuss whatever we need to discuss with them. This little handout comes to you in the email as well. So that's also in one of the handouts that you can download on the little webinar link there. But we do email this out to you when we've booked an appointment. So it's all there, very simple. Once you've done it once, you won't have any issues. You can text message and message back and forth. You can send documents, which we do use a little bit in terms of sending you some information about new medications, Ozempic, things like that, or even through to the patient if they're on the My Virtual Care. And then you just click on the attachment and download. They have a great IT support team. It's outside of Hunter New England Health, My Virtual Care, but they're really great and very prompt. So if you really are struggling, I would suggest calling us first, because our admin team is amazing and they can talk you through it. But if not, you can call these guys and you'll be on within 5 minutes. Okay, so please don't be, I guess the biggest feedback we've had is the apprehension to My Virtual Care. And I really want to sort of reiterate today that it's not something to be afraid of. It's very simple to use, nothing to do beforehand apart from click on a link, which I know you're all capable of. So yeah, that's me. I probably babbled too much, but I just wanted to highlight that, you know, the service is up and running. We're receiving calls. We're loving all the input we're having from people. Nothing's too minor and nothing's too major, obviously, either. And we have plenty of appointments available. We are going to have clinics over the Christmas break, so don't be worried that you won't get answered over Christmas. And we want you to call. Yeah, so we can help as many people as possible, particularly for the guys out rural that are having a rough time with COVID at the moment. So yeah, please call through. Awesome. I'm going to hand over now to Damien, who's just going to talk about his endo experience doing these clinics, and hopefully I can work out how to do that. Awesome.
Okay, thanks, Tamara. And firstly, I'd just like to acknowledge all the hard work that Tamara and others in our service have put into making this urgent care pathway happen. In terms of reflections, in some ways, the reflections are based on this replacing our usual Alliance clinics. And I gather many of you will have done Alliance clinics with us in the past. And with Alliance, I guess we've got a few goals in Alliance that are slightly different to urgent care. So in Alliance, clearly we've taken a strong educational leadership role with, an attempt to skill yourself up in your confidence dealing with diabetes problems, and hopefully having some spillover of effects to the rest of your practice, which I think we have shown in some research which is about to be published. In contrast, the urgent care model is clearly more about locating the resources closer to you in primary care and closer to patients. So I think from a patient and GP point of view, this is a very user-friendly service and a very sort of patient and GP-centered service. And I think all in all, it's achieving that goal. In terms of barriers, I think there's probably a couple of things that I've noticed having done a few of these clinics now that are a contrast to Alliance. And so I think one of the barriers are some of the issues that Tamara has brought up, which is clearly technology. And that is why we've made some changes around particularly the patient in engagement, ideally a face-to-face or patient in GP or just on the phone, rather than trying to achieve video conferencing with the patient as well, because that was introducing a lot of wasted time at the start of each consult. And I think the other thing I've noticed in the urgent care pathway compared to Alliance perhaps is that it's harder to have everyone in the conversation at the same time. We're often sort of waiting for someone to be available, particularly say a GP, if the admin staff haven't got things organised or identified the upcoming video conference with the GP. That often leads to a delay. Now, often that's not a big issue if we're taking a bit of history from the patient, but I think it does lead to some repetition, and perhaps it can also be a bit tiring for the patient and a bit confusing because they're hearing our conversations directly to the GP as well as the conversations to them. So in Alliance, we're typically careful about the way we communicate. So obviously we'll communicate with the patient using different language than how we communicate with you guys. And if I'm doing an Alliance clinic, I break up the time to focus on my communication with you, then the communication with the patient, then the communication with the GP again, and then allowing the diabetes educator to be actively involved. And I think perhaps that's where the urgent care pathway has less of the teaching embedded in it, and maybe has unfortunately does marginalise the diabetes educator a little more than we see in Alliance, where they've got a very active role in patient and GP and nurse, practice nurse education. So I think the great strengths of the program are the convenience to both yourself and patients, and I think it also does have the capacity to make a substantial difference in terms of picking up patients who might be at risk of decompensation or complications a bit earlier, and hopefully helping yourselves in general practice to get a handle on those patients sooner than you would normally. And I think that it also delivers a much higher quality service than just calling the registrar on call at John Hunter. So I think there's a lot to be gained from us being actively sort of reaching out to help general practice. The downsides, I think, are is it still creates a lot of follow-up for us, because it's not the same as seeing a patient face-to-face, and it's not the same as an Alliance clinic in terms of that real true multidisciplinary care where we can all be really clear about what we're agreeing to at the time. I think the things that general practice could do to help us, I think a lot of it's probably at the administration level. So I think just giving your administrative staff the permission to arrange things on your behalf and to make sure that you're open to trying to be connected on time roughly, because if we get out of kilter with the appointments, it does create problems for other GPs that are coming after you in the list. So I think as long as your practice managers and practice staff are aware that you're involved in this process and that you're keen for it to run to time, I think that can really help us and the other GPs that are booked on the same day. So the main barrier we've found so far is keeping to time where there's connection issues, particularly at the general practice end. less so at the patient end, to be honest. So that would be the main thing that I think you guys could help us with. And also just making sure that you do, if you do have any questions at the time, that you take the opportunity to get us while you've got us. And even potentially discussing affiliated issues around other patients you might be looking after. It's a good opportunity whilst you've got us to take that time, and that's something we certainly offer in Alliance. So I think I might leave it there and pass over to Wendy. Thank you.
Thank you to the Alliance team who've asked me to chat today. I'm Wendy First. I'm a diabetes educator and I've worked in some of the GP practices locally and with many of the GPs in this area, as you'll hear from Joe today. The urgent care model is a fabulous initiative that allows the health workforce in regional areas access to specialised knowledge of one of the best endocrinology teams in the country. Timely resolutions for those tricky, complicated patients that you just need a little bit of reassurance about. Reassurance you're doing the right thing or what other options are out there. You can call the number, the urgent care number, and speak directly to the team. And as you heard before, they answer within an hour at the very outside. It's so reassuring. All of us listening are acutely aware of the often isolating situation we are in outside the major centres. We have the opportunity here to make healthcare for our patients more accessible and elevate our own skills as well. If COVID has taught us anything, it's that we need to start using available technology to benefit ourselves and our patients. What was once scary is becoming less so. The My Virtual Care platform that John Hunter uses is very simple, and I have actually used it quite a few times myself. Importantly, there is no software download required, and that is often a scary thing for practices or anybody to have to download other software onto their devices. Importantly, the patients can be with you at the home or on their computer or their mobile phone. And I've just heard Tamara say that we're doing mostly phone now, but I have had a few instances where the patients want to come in with me, and that's perfectly acceptable too. Of course, internet's the other issue, and that does sometimes become an issue in regional areas, but this is the best option we've got, really. So the benefits of the patients are that they get up-to-date, timely, relevant input to their healthcare without many of the difficulties they usually encounter. It reduces costs across the board for them, particularly for travel, accommodation, days off work, transport, driving long distances into unfamiliar centres, getting lost, trying to park, asking family or friends to take time off to take them, especially if they've got restricted licences, because we all know no public transport anywhere up here. Finding care for other members of their family while they're away, whether it's elderly parents, whether it's children, whether it's even pets into boarding kennels, that sort of things, all big issues. And we know that it's a really big burden for patients having to travel to specialist appointments, and they often choose not to go. They often say, why can't you just do it, doc, or do I really need that appointment? Emotionally and socially, it's important that decisions about their healthcare can be made in the company of their own familiar, trusted GP, practice nurse, or allied health practitioner with support of family close by. They can choose to be involved on the day, or they can leave it to the GP. They can choose to come in or stay at home and log on. There's no software required, as mentioned earlier. Ultimately, this means also that there's less confusion about what happened when you saw the specialist. Health literacy issues are minimised and medication changes are communicated straight back to the treating team, both verbally at the time and then in a written format later. Thus, both medical team and patients feel empowered and cared for. Benefits for the health professional are that there's immediate feedback at the time and again within hours in a written form usually. There's chance for ongoing education in the specialty area, and as Damien mentioned, you can ask other questions at the time as well. Ongoing network opportunities, less apprehension the next time you do it with your face to the name that you've been writing letters to for ages. Improved clinical outcomes with timely service, and importantly, this model gives support for a specialist team, with support from a special team, reduces the isolation and may even help us retain rural workforces in the long run, which we know living rurally is a big problem. My direct patient experience has been a couple, but particularly with the one that Joe's going to talk about in a minute. We had some discussions regarding this patient prior, and then the decision was made to escalate it to the urgent care team. An appointment was made by the team as they couldn't answer it right on the spot, and they deemed that it was necessary to escalate it to a My Virtual Care appointment with the endocrinologist. Appointment was scheduled, all parties received a link, and importantly, they did all the hard work about doing all that and informing reception. GP had to write a referral and send the staff off, but that was the only real burden. I also received a link, and I could be there with the GP, or I could be in my own office or in another part of town, or I could have the patient with me instead of with the GP, whatever was more suitable for everybody. The advice was immediate and practical, and at this particular time did not even involve a medication change. The patient chose, in this case, not to be involved, but they were very happy to know that the GP and the DE had rung and spoken to the specialist. The patient felt listened to. He felt he was receiving good care, and we instituted some changes that he was fully involved in and informed about. I've had 2 other occasions to be in contact with the team recently. One was a high-risk patient that I was seeing, and I was concerned, so I rang the line directly myself, and they determined that, yes, it was worth having a chat with the endocrinologist, and they then arranged the GP follow-up so that we could all be on the call together. In this case, the patient wanted to come in with me. Again, technology, as Tamara mentioned, is a barrier to a lot of patients, and it may be that some of them don't have devices or don't have consistent internet. A lot of them in some fairly poor socioeconomic situations as well, and we're all aware of that as well. So the options to come in are really a great consideration. I also, in another occasion, was talking to a young GP new to the area, and I just happened to mention that this was available, and they were so excited, and they immediately utilised the service. And so that's a really good option for them, and really helps them be supported when they're actually away from their home, their town, their family, doing rural placements, and to know that they've got support of a specialist team is really empowering for them. This would be a great model of care to use across all other specialties in the area. Wouldn't it be fantastic to have this service in other areas? Feeling supported contributes to the health and well-being of our fabulous rural workforce. And I'd like to emphasise that this initiative is not limited to the GP. It can be accessed by allied health and practice nurses wanting advice. And there's also potential for remuneration through case conferencing IPN numbers for allied health as well. This model will not exclude the need for face-to-face appointments, but certainly it plays a role in the GP, allied health, nurse, care worker support in rural areas. Please support this initiative. It may just change the outcomes of care for your patients, and hopefully it will be a model to take into the future for other specialties as well. Thank you very much, and I'll just now hand over to Joe.
Thanks, Wendy. And thank you, Charles and Tamara, for the opportunity to contribute. I'm Joe Ferris, and I work as a GP in Foster. I've worked in rural or remote general practice for over 30 years now, and specialist access has always been an issue. And I'm grateful to the Hunter New England Health Network for the efforts it has made through the Alliance and now through the urgent care model. I've had a chance to use the urgent care system for diabetes management and think it has a lot to offer. I had a complicated type 2 diabetes patient on insulin with multiple comorbidities who had developed yet another comorbidity and was getting very difficult to control. I discussed the patient with Wendy, changed needle sizes, checked his ingestion site, obtained a blood sugar and food diary from the patient, and things still weren't making a lot of sense. So I thought I'd give the urgent care number a ring. An actual human being answered the phone. I think I spoke to Tamara. It was a very comfortable conversation, and she quickly realised I would need input from an endocrinologist. I think she made a teleconference appointment for me a few days later then and there. Our practice runs on steam-driven computers, so she emailed through a referral form, which I was able to complete and fax back. I included some relevant history and pathology results, as well as his recent blood sugars. I believe there are much more efficient ways of doing this, like via things like eSent, which a lot of practices are more familiar with than me. The teleconferencing part of it was also straightforward. I was sent a link which I was able to open on my phone without having to download and install anything. I didn't have the patient with me on that occasion. Apparently, if I did, he could have been in the room with me or on his phone at home. In the past, in this situation, I would have made a phone call to an endocrinologist I knew, who would probably return my call out of hours. I would not be able to convey much information over the phone in a short time. Would probably not have the patient's details at my fingertips. The endocrinologist would essentially be working blind, and I'd get some reasonable but pretty generic advice. The advantage of the urgent care system is the endocrinologist has significant amount of information about the patient, including pathology and blood sugars and its extensive medication and past history list. I had all the patient's notes and pathology in front of me. We were able to have a useful chat and come up with some management options. Not only that, I received a written summary of the consultation within hours, so I didn't have to rely on my dodgy recall of an out-of-hours phone call. And there's actually an item number for it. By way of contrast, at about the same time, I was having difficulties with an elderly patient with chronic lymphocytic leukemia, and I felt I needed input from the hematologist, so I used the phone method. This only worked because I've known the hematologist for over 20 years. He had treated the patient for years and had access to her latest pathology, but he returned the phone call in my car on the way home. It would have been impossible if I'd been trying to explain things from scratch to someone I didn't know about a patient they didn't know. The outcome would have been a bit dubious, and all this is done gratis, no billings. It might take a bit more time to set up an urgent care consult than a simple phone call. Probably not much more for the more computer savvy practices, but the outcome is, in my opinion, so much better. On the day, things went quite smoothly at my end. Maybe not so at the other, because the diabetes educator had to vacate the building due to an earthquake. Nevertheless, I think this is a great system that has potential to decrease a significant gap in specialist accessibility for rural and remote practices. Once again, thank you for the opportunity to contribute, and to the other GPs watching, please give this system a go. It will benefit you and your patients. Thank you, and I think it goes back to Charles.
Thanks, Joe. We might move into the Q&A component, and I'll hand over to you, Tamara, to initiate that. If Wendy, if you'd like to
I feel like
pop
I need
your...
to follow the wine, Wendy and Joe, talk about sales, and yeah, wow. I'm going to be going for a pay rise after this to the boss, that's for sure. But thank you. It's so good to hear from you guys and your perspective from your end. And Damien too. I know we've had conversations in person and talked about some of the feedback, and hence we've made some changes. So we're always happy to hear the pros and the cons. And like anything, new models, new times, and like Wendy said, with COVID, we've had to adapt definitely to the virtual world a little bit more, and definitely quicker than we had hoped. But I definitely think there's a place for the future in the virtual world. So a couple of questions has come back through. Damien, this one's for you. Have you found that many GPs ask questions during the case conference, that it's quite collaborative, or is it more so specialist led?
Yeah, look, I think probably it's less collaborative than an alliance clinic, I would say. And that's partly because in an alliance clinic, you've got the capacity, like I was saying, to kind of break the room up into different sections. So you can have one-on-one conversations with the GP or one-on-one with the patient. But I think in this kind of model, particularly if we're all in different sites, it's more difficult to make it a bi-directional discussion with the GP. And I think partly also because we're slightly conscious if we have a very medical discussion, that can alienate the patient a little bit. And I found one of my consults today, I spoke to the patient and the GP got online, we had a chat and we were talking about, look, these are the things to do in the next 6 months. There's quite a bit to go through. And then the patient and her daughter were a bit unsure about whether they were still involved in the conversation. So I think I think we should have more interaction, so you guys get the most out of it. So it's a good opportunity to ask questions about, you know, what the plan is for this patient, or if you've got questions around the use of these medications in similar or slightly different scenarios. So I think take the opportunity, and I think it's probably just our job to make it clear to the patient and any family that are involved that, look, just bear with us, guys. We're just having a conversation as health professionals on the side. We haven't forgotten about you. So perhaps it's a bit of learning from our point of view, just to manage the what's going on, so the patients realise when we're talking directly to them or when we're speaking to the GP. But I think the GP should really take the opportunity. I think all of the different you know, consultants that are involved are happy to talk about other things. We're all general physicians as well, so I think everyone's happy to discuss other things. So I'm pretty sure I can speak on behalf of my colleagues and say, you know, you can ask questions, and I think it's much more useful if you do.
Yeah, definitely. And then one for Joe, it says here, would you invite patients in the future?
Yeah, I'd have no problem having the patient actually in the room with me at the time. I think to me that would work better than having them on the end of the phone, and then it might solve some of the other issues with trying to work out who the conversation's directed to as well. I think if the patient was actually with me, my patient base is not young, and a lot of them, I must admit, I've been surprised how capable they've become over COVID with handling devices, but I still think they would struggle a bit.
Yeah, and I guess the benefit of having them in person is that, you know, scripts can be written, pathology forms can be written, and they're handed off directly, versus having to come back for another follow-up appointment, etc. So another question is around the billing numbers. So for a 20-minute consult, it's a 739 is the MBS billing number for a case conference. That covers the 20 minutes that we usually find on average that we're spending with the GP. There are less times and more times. I think it's a 742 for a bit longer off memory. And the allied health numbers, I don't have at hand. Wendy, do you know them? So that just recently in the last few weeks, Medicare have come out with some numbers that allied health can actually claim for being involved in the case conference. So if you do have, you know, a CDE or a dietitian, or we've even done one with a exercise physiologist being involved, they can actually claim their own Medicare billing number for the case conference. Have you got the numbers at all, Wendy?
I don't have them, but there was a whole webinar just recently on that.
Yeah, so, right. Yeah, that was on there.
It just came out
in their library on the PHN. Yeah, if you look it up on the PHN webinar library, it's there, I'm being told, so that with the specific numbers. But yeah, so it is like Joe was saying, in terms of, you know, you are getting financial reimbursement for your time, which you don't get if you're getting your after-hour calls and just ad hoc phone calls here and there, which is important, particularly in private business, obviously. Yeah, so there's no more questions. I think we'll wrap it up because we've got 2 minutes to go. Charles, do you want to say your final farewell?
Yeah, thanks, Tamara. Thank you, everyone. Yeah, you can relax now. Excellent job. Yeah, just want to say a big thank you to Tamara, Damien, Joe and Wendy for presenting today. Appreciate your time, and thank you to everyone who has joined us over their lunch break and sending in your questions. Just a reminder, this session is being recorded, so it will become available in our education library on our website. If not this afternoon, definitely tomorrow. So please feel free to share that link with any of your colleagues that may have missed it today. There will be a short evaluation survey that will pop up in a moment when I end the webinar. If you could just take a minute to fill that out before I log off, we really appreciate your feedback. It's also an opportunity to let us know of future topics that you'd like us to cover. So that's all from me. Thank you again, everyone, for joining us, and we hope you enjoy the rest of your afternoon. Thanks.
Thanks, Charles.